All right, good morning, everyone. Thank you, Dr. Chogley and organizers for having me here today. Unfortunately, I cannot deliver this live over there in person, but I'm sure looking forward to meeting, my friends and colleagues. Nevertheless, thank you for the opportunity and for giving me the task to shed light on the molecular landscape of NSCLC. So without much further ado, let's get started. So the first question, what have we, wait, my slide's not moving. Oops. Okay, you go. So what have we learned about lung cancer? So we've learned that it's possibly one of the most molecularly diverse cancers. I mean, even if you just look at the NSCLC in particular, and just look at how it's evolved. We've gone from treating NSCLC as one large homogeneous group to slowly we've moved on to categorizing it based on histological subtypes. And even from there, if we just look at the adenocarcinoma subtype, it is molecularly diverse. And so I want to draw your attention to this, greater than one oncogenic driver mutation, which constitutes around 3% of our cases. And to keep this number in mind, I'm going to revisit it in a bit. So what does the landscape look like for us in 2022? Now, this is a screenshot from the most recent NCCN guidelines, which recommends a minimum of EGFR, ALK, ROS1, KRAS, BRAF, NTRK 1, 2, 3, MET exon 14, RET, and PD-L1. It's like gone are the days when it was like at least an EGFR, ROS1, EGFR, ALK, ROS1, and PD-L1. And it's not just in the adenocarcinoma type, even in our squamous cell carcinoma. So just very quickly, what are the sample options that are available for us to do molecular testing? Tissue has always been the gold standard, no argument there. So at diagnosis, you do a biopsy. At progression, you do a prior biopsy, preferably from the new metastatic site. However, the ground reality is that while we'd like the blocks to look something like this, tissue can be an issue, and to combat tissue being an issue, liquid biopsy is a good alternative, especially in a stage 3B and greater lung cancer. You isolate the circulating tumor DNA from the bloodstream. ctDNA is the somatic DNA that is released from the cancer cell into the bloodstream, and the ctDNA is isolated, and molecular, or as we say, tumor profiling is done. And one of the key apprehensions or concerns with liquid biopsy has always been its concordance with tissue biopsy. And through the Nile slip studies, we've seen, especially in our advanced NSCLC cohort, a concordance of as high as 98%. And in addition, where I think liquid biopsy has a couple of pros versus tissue biopsy, because it's a non-invasive test, you can actually use it to, monitor treatment responses. You can monitor resistance mutations, and in addition to that, you can address that issue of tumor heterogeneity. So in the recent NSCLC consensus statement that was led by Dr. Christian Rolfo, we were reminded that there are some key differences between tissue and liquid biopsy in lung cancer. So with tissue biopsy, of course, we get the cancer diagnosis and pathology information. You get an assessment of markers like PD-L1 that are non-genomic. But of course, tissue is harder to get. It takes a slightly longer time to get results, and it's also challenging to repeat biopsies, and it's not as reflective of the tumor heterogeneity. Liquid biopsy was found to be highly concordant, fast, minimally invasive, and easy to repeat over time, and perhaps better to capture tumor heterogeneity, although unfortunately it's not always as sensitive as tissue testing. So of course, if you don't find something on liquid biopsy, it's very important to try and do a reflex on tissue biopsy. And now in the clinic, what they further advised was in treatment naive patients, there were at least 3 approaches that were recommended for liquid biopsy use. The first one is a sequential approach where tissue testing has failed. Second one is a complementary approach where you do both liquid and tissue simultaneously. And the third one is a plasma first approach, where it's clear, that we're not going to be getting, we're not going to have sufficient tissue, or surgery or biopsy is not an option, or the tumor is inaccessible, then we go ahead and we do a liquid biopsy. So, while there are multiple validated platforms and technologies that are available to call out these different biomarkers and the somatic aberrations, NGS is fast becoming the preferred platform of choice. So I'm not going to be belittling the standard of care platforms like RT-PCR, FISH, IHC, because I feel, they are the standard of care. You can't belittle them, but I do feel where NGS, with NGS, we actually get answers to the tumor biology in one sitting versus the standard of care platforms. And in addition, NGS is proving to be more cost effective, improved turnaround time, tissue preservation is there, but the key points for me is where NGS kind of has an edge over the standard of care is that you have the potential to discover more actionable targets. And remember the pie chart I showed you earlier, where 3% of advanced NSCLC cases, patients actually have multiple oncogenic driver mutations. Well, NGS calls them out in one shot. So all this in turn actually helps guide and chart out a more personalized treatment for our patients. And if you just look at this in particular, this is from my clinic. This is data from my clinic, which again, over here, if you see, it proves the point of concomitant genes that are there, which has been done on NGS, and we've been able to call them out. So you've got EGFR with ALK, EGFR with MET, you've got KRAS, you've got EGFR with EGFR, and we know different variants of EGFR respond differently to different therapy. So you're giving the patient a more personalized approach. So let's use a biomarker we're very comfortable with in our clinic, like EGFR. So in an unselected population, from there you identify, let's say, an EGFR mutation, you put your patient on a TKI. After a period of time, they're going to develop a resistance, and we use imaging to confirm, it. Then we do a rebiopsy, preferably from the new metastatic site, or if rebiopsy is not an option, we do a liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. And we've identified that, as we all know, the most common resistance mutation is the T790M, accounts for 60% of our cases. However, in addition to this, we have a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, your HER2, and more importantly enough, your small cell transformations. Now, we also have patients who progress on osimertinib, and it obviously acquires resistance mutations. And in the AURA3 trials, we saw that 15% have C797X mutations, 19% are positive for a MET amplification. You've got HER2 amplification, which are around 5%. And this is why next generation sequencing, and this is so important, and this also proves the point as to why NSCLC is possibly one of the most molecularly diverse cancers. So this is our algorithm. Lung cancer has always been the poster child for it. And this is where we are. These are our biomarkers and the different lines of treatment, these are the different treatment options. So let's very quickly get familiar, because I know there are a lot of talks coming where everyone's going to be specifically talking about each of these biomarkers. I'm going to very quickly run through them. So we've got NTRK1, 2, or 3. These are fusions. They're very rare. They're around 0.3% of our NSCLC cases. These are agnostic markers, and these waterfall plots for entrectinib and larotrectinib actually illustrate the majority of solid tumor cancers, lung cancer included, responded very well to TKIs. Now, the rearrangement of NTRK gene, it actually couples with the tyrosine kinase domain with a 5' fusion partner, and it generates a chimeric TRK protein ligand binding domain, essentially a fusion. Now, the most common fusion partners that we have seen in NSCLC is NTRK1 with TP53, CD74, and TPM3. NTRK3 we see with ETB6 and EML4. Now, this is a flow chart that is of testing that is recommended by ESMO, but in my very humble opinion, I think NTRK are translocations, be it 1, 2, or 3. NTRK has a low staining on IHC, whereas NTRK3 has a low staining on IHC, and NTRK1 has a low specificity and sensitivity by FISH. Thus, the preferred platform here is NGS. And in addition, it's RNA NGS because it's fusion, higher sensitivity and specificity. And the same is also being echoed in multiple international publications. RET, a biomarker that's synonymous with papillary thyroid carcinoma, but actually constitutes for 1 to 2% of our NSCLC cases. So RET gene rearrangement actually gives rise to chimeric cytosolic proteins with constitutively active RET kinase domain, in short, again, a fusion. And KIF5B is the most common fusion partner, followed by CCDC6, which is seen in NSCLC. Again, it's a fusion, so RNA NGS is your preferred platform. Therapy options, selpercatinib, that we get from the Libretto 001 trials, and you've got pralsetinib, which is the blue 667 from the ARROW trials. Then we've got the MET exon 14 skipping, which is essentially a mutation that occurs at the junction of exon 13 and exon 14. And this leads to the skipping of exon 14. And what you're looking for is a product fusion of exon 13 and exon 15 that gets formed. Again, it's a fusion. So I think as a general rule, be it for ALK, ROS, MET, NTRK, anytime we're looking for a fusion, it should be RNA NGS. So when you get an NGS report, if it's negative, go back and check with your service provider, was it DNA or an RNA? If it was DNA as a reflex, I would urge you to go in and do an RNA NGS. And in the cases of MET exon 14, we got crizotinib as a treatment option from the Profile 1001 trial. We have got capmetinib from the Geometry trials, and we've got tepotinib from the Vision trials. KRAS, this is the most common mutation we see in our NSCLC cases. They constitute for around 25 to 33% of cases, especially in the smoking cohort. So you're essentially looking for mutations in the GTP binding protein that connects to the receptor of the tyrosine kinase. And again, from this subtype, the G12C, it's the most common. It constitutes for around 40% of KRAS cases. And what's interesting in this subgroup are the varying TMB rates. So G13 is the highest, which is followed by G12C, and G12D has a propensity for a low TMB rate. Even the PD-L1 rates over here, it's a high, which is a TPS score greater than 50%, is G12C and G12D. And from the AMG 510 trials, we've got sotorasib as our treatment option. And again, when we're talking about treatment options, we do have PD-L1, which slide I seem to have missed. We've got our clones 22C3, SV142, SV263. We've got multiple trials that have shed light and proven as to why one should do testing upfront and its importance, and that's why in the NCCN it's called out immediately. But one of the new, slightly controversial biomarkers, especially in immunotherapy, I personally feel is tumor mutation burden. So the key theory here is that every cancer's got a mutation. More the mutation, higher the neoantigen, and possibly a better immune response. So in the lab, on a minimum of a 250 gene panel, we look at the number of genetic aberrations in the exonic region. This gives you the incident idea of whether or not the tumor that you're dealing with has a high or low neoantigen load. However, here's where I think there's a slight issue with the theory. Not every mutation will cause the tumor to have a to actually have a neoantigen, that may, and the antigens. But it may also not necessarily be a neoantigen. So that's being recognized by the immune system. So I personally feel that the neoantigen may not really induce an immune response. And also the one size fits all of the TMB score of greater than or equal to 10 mutations per megabase may not really be ideal. But the FDA has given a blanket approval. So I think it's still experimental. I think every solid tumor has its own different cutoffs, which we still need to identify, but push comes to shove, you've got your back up against the wall. I think Foundation Medicine has amazing data around it. And we've now got Thermo Fisher, which again has some fantastic data. So you've got the high end and the domestic partners, which are giving Thermo Fisher's TMB, which makes it economical to our patients. And I've just got 2 more minutes and I'm done. I just very quickly wanted to just, whatever was spoken, to actually illustrate them through cases. This is a 50-year-old female NSCLC, and over here they did sequential, testing, the very quintessential EGFR by RT-PCR, ALK by FISH and ROS, ROS1 by FISH, and PD-L1. Everything came negative. She was 50, she was young. So at this point, we luckily have some tumor. We sent it for NGS, and a BRAF mutation was detected. She was started on a BRAF, with a MEK inhibitor. Similarly, a 79-year-old male who was EGFR positive started on afatinib. We know he was going to progress. He eventually progressed. Rebiopsy, no mutation was detected. 79 years. Keeping his age in consideration, we sent him for a liquid biopsy. A MET exon 14 skipping mutation was detected. A VAF as low as 0.4%. Now, because liquid biopsy has a higher depth of coverage, that in turn results in higher specificity and sensitivity in calling out these mutations. It is also because of tumor heterogeneity, and this patient was immediately started on capmatinib. And my last case is of an 81-year-old female NSCLC. Tumor was insufficient, so liquid biopsy, was done. We found a ROS1 mutation. She was started on crizotinib. She progressed. Refused tissue biopsy. We again sent her for a liquid biopsy. ROS1 fusion persistent. She had acquired a ROS1 G2101A mutation. It's a known crizotinib resistance mutation. So her physician put her on lorlatinib at this point. It was short-lived. She again progressed. A liquid biopsy was repeated. And we saw that the ROS1 was persistent, but she had lost the ROS1 2101A but I need 1 more minute, I'm just done. But gained a ROS1 G2032R. In addition to this, we had lost the KRAS K117N, and now we had a KRAS 12D, which would have been imatinib is a targeted therapy, but this could be a potential CHIP mutation. And this is something clonal, CHIP is essentially clonal hematopoiesis of indeterminate potential. So you've got to be very careful when you see TP53, KRAS, JAK2, anything with a VAF less than 0.1%, they may not always be actionable. And I think, this slide, I think best sums up this pie chart, best summarizes my talk. Around 50% of our patients with advanced NSCLC have a driver mutation. And if it's not, that's targetable. And if not, there is some other FDA-approved drug or agent. There's some other clinical trial that I've highlighted here in red, which is obviously going to increase the cohort of patients that can benefit from molecular testing. And on that note, thank you very much for your patient listening.